Hello, Assalamu alaikum. Students, how are you? Fascinating. ठीक ठाक हो? Today I have to discuss the topic of rhinitis. But I will remind you again once that in the previous two lectures, I got assignments reply from very few students. And keep in mind that your attendance, on the basis of your receiving assignment on the email, will count to your presence or absence. From those from which I have received the assignments will be considered present, and those who didn't send their assignment on the email will be considered as absent. And on the basis of the assignments and marking, you will get your marks and you will be evaluated on the basis of these as an internal assessment. So I will share with you within a few days those who are absent, considered absent, and those who are considered as present. And all these record will be sent to the medical examination section for your future record. So coming to the topic of rhinitis. Rhinitis is actually a broad term, and it can be acute or chronic. But it is broadly divided into allergic, non-allergic conditions. Some are of primary involvement and there are of secondary involvement. So locally or secondarily, signs symptoms we can come across in patients having rhinitis, acute, chronic, allergic, non-allergic, infective, non-infective. There are multiple types of. So next, the classification, on the basis of that classification, is infectious, whether the rhinitis is infectious, allergic, occupational, drug-induced, hormonal, or other causes. In infectious, viral, bacterial, and other infective agents are common. Allergic, that may be intermittent or persistent. Again, the occupational, that the person is working somewhere or exposed to some environmental allergens or allergic conditions. Drug-induced, aspirins and some other medications like cardiovascular medicines that affect. Hormonal, again, hormonal depends upon, especially in the female, estrogen progesterone imbalance that will be discussed later on here. And other conditions, we can say that the patients having exposure to some irritants like especially environmental conditions are mostly come into account. Then the food, gastroesophageal reflex disorders, emotions, these are also, or atrophic rhinitis, these are also conditions that affect the other, you can say that the other conditions are also involved in. If come to differential diagnosis, which is the most important, if the patient comes to you with a history of rhinitis, that will sign and symptoms, that will discuss how will you differentiate and what differential diagnosis must be come into your mind. Polyps, we have discussed the polyps in the sinusitis a bit, because the nasal obstruction with the polyp, nasal obstruction can occur. Some mechanical factors like deviated septum or adenoidal hypertrophy, foreign body, choanal atresia. All these terms you will come across step by step while you are studying your books also. So these can come in differential diagnosis. Tumors that may be benign, malignant, granulomatous conditions like Wagner glioma, sarcoidosis, or infectious malignant, midline destructive granuloma, T-cell lymphoma. These are ciliary defects. Ciliary defects, actually, it is a pathophysiological conditions in which may be a congenital. or acquired, in which the cilia are affected and this ciliary function is abnormal, either congenitally or acquired. And in that conditions, again, the rhinitis, these conditions, ciliary dyskinesia, especially these, comes in the under the heading of rhinitis. So you can, on the basis of we come again to the basis of differential diagnosis, you must know how you can label a patient and what conditions can be in such conditions. Like if we talk about these infective rhinitis causative agents, in which the most common is virus again, then bacterial, and then some secondary infections occurs like aerobic and anaerobic bacteroides, actinomycosis, diphtheria, rhinoscleroma, tuberculosis, and fungals. All these conditions are comes under the heading of infective rhinitis. So, depending upon the sign and symptoms, age, occupation, environmental factor, exposure to environmental factors, we differentiate such patient and come to a proper conclusion or proper diagnosis. The diagnostic techniques, how will you diagnose such patient, is come to you. The diagnostic techniques actually assessment of symptoms. For the most of the time, we differentiate one disease from the other disease on the basis of the symptoms that you see in the patient. The patient give you history, and on the basis of that history, you able to make some differential diagnosis and come to a final diagnosis. So this is important. Then examination, as you have discussed, that if the patient is having a polyp, we are labeling it as a differential rhinitis, and we examine, we see a polyp or deflected septum, or some foreign body, or some atrophic conditions in the mucosa. So we can label it on the basis of history and examination. Some tests, allergy tests like skin tests, serum immunoglobulin E, or specific serum immunoglobulin E. Endoscopy again is important, rigid or flexible. Endoscopy is important in some way other when we take some secretions or swab from the nose. In that condition, we also have a direct vision visualization of the nose or the posterior nasopharynx, so that we can take a swab or secretions for purpose of diagnosis or purposes of lab bacteriology, or we can do a culture sensitivity for that. Rigid or flexible endoscopy have importance. Then you can have some radiological examination like CT, MRI, or plain X-ray. Because the previous lecture, we have discussed that isolated rhinitis or sinusitis are very uncommon. Usually the involvement of the sinus, to some or less or more extent, involvement is there. So just confined to the nasal cavity, this is not the proper way. We have to look and have an assess on the basis of examination, history, and investigation of the sinuses also, so that we may not miss any point. Next, the mucociliary function. As the mucociliary function, we say that the nasal mucociliary clearance and ciliary bead frequency and nitrous oxide. These are the conditions, these are the tests in which we come across some clue of about the diagnosis of the patient. Mucosal function, the ciliary beat frequency, this is the ciliary cilia, which propel or propagate in a specific way to the nasopharynx and clear the mucosal lining or mucosal blanket into the nasopharynx and avoid the stagnation of these secretion into the sinuses and the nasal cavity. If ciliary function is affected, these stagnations occur, which superimpose the bacterial infection, and the patient is having the condition getting worse. Because ciliary nasal mucociliary clearance, this is a test in which, in a way that is a saccharide type of block is placed at the anterior turbinate, at the end of anterior turbinate, and the time is noted that how much time it takes that the person feel a sweetening effect, a sweetening taste in the mouth, and on that we can say that the mucociliary clearance is normal or it is abnormal. The basis of that we can. Okay, next we can say that about the nitrous oxide. Nitrous oxide is usually it is found in the in the sinuses, and if the nitrous oxide, the upper and lower respiratory, if there is polyp or some obstructive conditions in which the sinuses are blocked, so these nitrous oxide, which in the line the sinuses, it is made in the sinuses. On the concentration of that nitrous oxide, we can say that the patient is having some problem in the sinuses, blockage, exchange of gases. So the concentration of the nitrous oxide in the sinus is again of importance. Blood test, for blood test, you do the full blood count, ESR or thyroid function test, depending upon if we are suspecting some other conditions, secondary condition that are the maybe the factor for the rhinitis in the patient. History examination, that is nasal congestion, discharge, sneezing, headache. These are the novel symptoms that we can see in the sinusitis, in the rhinosinusitis patient or the rhinitis. Specific questions usually we ask about the rhinological symptoms, like the patient is having sneezing, itching, epistaxis. These are some specific questions which are related to the rhinitis. Other than these, nasal obstruction, you have to ask the patient nasal obstruction on the same side, both sides, duration, frequency, that we usually ask about nasal obstruction, so that we can get a clue that the patient is having DNS or polyp or some sort of tumor or other congenital abnormality. For hyposmia or anosmia, again the patient is investigated or asked the question especially about that, at which area is involved, which region is involved in the nose, that the patient is getting the symptoms of hyposmia or anosmia. Secondary symptoms, for the secondary symptoms due to blockage of the nasal cavities, usually we get in the history, we get some clue or answer from the patients, that the patient reply that the patient is also having a sore throat or mouth dryness, or sometimes hyponasal voice, that is nasal voice. We also usually called it as a nasal voice. So these are the other symptoms that are not directly, you can say, with the nose or the sinuses. Other than the nose and the paranasal sinuses, other symptoms that are, these are associated with rhinitis, but secondarily, not primarily. So the primary region of the nose and sinuses, these are not the symptoms of the primary regions, but of the secondary region like pharynx, hypopharynx, larynx. So you have to ask this question also. Drug history, again, the drug history is important because there are many drugs that are that may be a source or cause of such condition. So drug history is also important. The quality and the quantity of the secretions. When we are examining the patient, definitely if we do anterior anoscopy and we see secretions, thick, mucoid, foul smelling. So these points should be noted that when you are doing anterior anoscopy, so what you can see there is there is a normal dry, the nasal mucosa is dry, it is pale yellow, boggy, reddened, or there are secretions, the secretions are watery mucoid, or it is purulent, or it is yellowish, greenish, foul smelling. So these are the points that we must take into account. Viscosity, correct? These are all. And again, for the swab, when we take a swab, we take it from the middle meatus because osteomedial complex is there. And from the middle meatus, this is the very important points from where the secretions can come out, and we take a swab and we can get a proper bacteriologically or cultural sensitivity result. That I have discussed already at the mucosal appearance. Mucosal appearance, that is whether it is red, yellowish, pale, what sort of. Because in the non-allergic acute conditions, infections, the mucosa is usually red. And in typical allergic condition, the mucosa is pale yellow. So again, the examination inspection of the mucosa is again very important. In granulation conditions, like vaginal granulomas, the mucosa is friable but reddened with crusting. In that condition, now the mucosa is not moist. It is crusting, reddened, and when you touch or peel, it get bleed. So presence of such epistaxis or bleeding points, or is you have to differentiate it from other conditions. And examination of nasal cavity, definitely we are repeating this. I'm repeating this point again and again. That on examination, you must have all the things in your mind, like polyp, tumor, foreign bodies, septal deflection. All these things must be in your mind. Presence of septal perforation. Yes, again, there is a patient is having a septal perforation. This may be either due to some granulomation conditions like granuloma, etc., or it may be due to trauma, or it may be due to surgery, like septal surgery. Usually with septal surgery, the perforation occurs. So these are the different conditions when we examine the patient and we came across and we see. Physical examination, that what I was asking you, telling you that the physical examination should not only be confined to the nose, but the posterior endoscopy or IDL or neck palpation. Yes, neck palpation. If he sees something like abnormal mass in the nasal cavity, and the patient is having a nasal obstruction, and we see abnormal mass with bleeding or something like that. And for that, if we suspect that it is a tumor, so definitely we have to do the neck examination. But in selected cases, many conditions affecting the nose and sinus also affect the lower respiratory tract, which may reveal by appropriate examination. Imaging again, plain X-ray, CT, MRI, depending upon the condition, which patient which is needed. So that mucociliary function test, that is mucociliary function test, which I have told you, the mucociliary function test. For the mucociliary function test, what we do, we put about 0.5 mm of a saccharine piece on the where at the anterior end of the inferior turbinate, And we ask the patient that when he get a sweetening taste in the mouth, the patient should tell us. And if it is normal, the patient feel a sweetening test of that saccharine within 30 minutes. If it is prolonged, more than 30 minutes, 40 minutes, 1 hour, then it is an abnormal ciliary function, mucociliary function. Or if the patient appreciate the taste within 30 minutes or less than 30 minutes, then it is normal. So this is mucociliary function test. Blood test hematological investigation, depending upon the suspected differential diagnosis for thyroid. If we suspect thyroid dysfunction and TFTs for granulomas, we do some specified test. The main thing here is etiological factors, which you must know very clearly, that they may be congenital conditions that the patient is predisposed to respiratory tract infections. It means that there is a congenital condition, and later on the patient predisposes the respiratory infections, and that are the primary ciliary dyskinesia. In this, the congenital abnormality is in the cilia. And the what congenital abnormality? The cilia have an abnormal mobility. And if the ciliary movement is abnormal, then the clearance is not proper, and the patient usually get the upper respiratory tract infection, upper lower, both, yes. And it is called primary because it is congenital in nature. And you can what happened in it? The serous otitis media. We usually see this primary dyskinesia in patients with serous otitis media, even other than the sinusitis and other than the upper lower respiratory tract infection. Sometimes in very rare cases, due to this generalized ciliary dysfunctions, primary ciliary dyskinesia, there is a infertility problem also. Next, the cystic fibrosis. It is caused by a defective mucosal chloride, chlorine transport gene, and viral infection. In viral infection, common cold is the most common one. Viruses are usually associated with the upper respiratory tract infection, but only 0.5 to 2% of these become bacterial infected. Otherwise, almost always a common cold is of viral in nature. And what happened? The virus is normally transported to the nose by direct contact with the fingers rather than the airborne contamination. Mostly it is by the direct contact of the nose with the nose. And there are 3 phases: dry phase, catarrhal phase, and mucus phase. In the dry phase, the patient is having headache, myalgia, or shivering, like shivering, fever, extra. These occurs, and it is usually after 1 to 3 days of incubation period. Sneezing sometimes, and irritation sometimes, nasal obstruction. All these occurs in dry phase. Next is the catarrhal phase. That follows few hours later, after the dry phase. And in the catarrhal phase, there are profuse watery secretions, as the name signifies, and nasal obstruction, and sometimes decrease in smell sensation. In the mucus phase, the symptoms improves, or it continue after 5 days. If it continue after 5 days, then there is expected that the bacterial infection has supervened. So the first 5 days, 1 to 5 days after incubation period, the dry phase occurs, then the catarrhal within a few hours, and up to 5 days. After 5 days, if it is subsided, then the mucus phase subsided yet. But if it's not, then the bacterial infection is supervened. And then we have to, sometimes the other regions, other area like tonsil, pharynx, these are also involved. And it is usually with the bacterial infection. Other predisposing factors, climatic, environmental changes, fatigue, stress, all these contribute. Treatment is just symptomatic, decongestant, antibiotic. Sometimes oral chlorpheniramine, these are bromide may be effective if taken early in the primordial phase. Otherwise, no, there is no role. Antibiotics only. Antibiotics are antibacterial, and in antibiotics we give antibiotics only and only if there is superimposed bacterial infection. Otherwise, no. Topical nasal corticosteroids we give usually to the patient the virus infection in the early phase. One of the condition of the nose or rhinitis is the folliculitis or vestibulitis. This is a very serious and very, we can say that patient can having a very much pain and discomfort because the Streptococcus aureus, which invades the pilosebaceous follicles, and when it is involved, the skin, which is very tightly adherent to the cartilage, nasal cartilage, these infection get in that space, and the pain is very, very, it is very painful condition. And if it bursts, then the purulent discharge comes out. So in such condition, local clinic and systemic antibiotic, because this is a bacterial infection. So antibiotics which include the flucloxacin are given to the patient. And if it is getting worse or if abscess develop, then incision drainage is done and the pus is drained out of the folliculitis where the lesion is occur. And secondly, that the complication of such condition is very serious. Cavanaugh sinus thrombosis is the condition which occurs in this such disease, followed by such disease. The reason is that it is a retrograde spread, and the reason is that the cavernous sinus, between the cavernous sinus and nose and some other region like pharynx, nasopharynx, orbit, and paranasal sinus, there are valveless venous system. So the infection can very easily spread retrogradely, that is to the cavernous sinus. And if the cavernous sinus thrombosis occurs, then there is a very serious problem in the patient. Is mortality rate is also very high in such conditions. Non-allergic conditions and non-infectious conditions. One of them is idiopathic vasomotor. Whenever the term idiopathic is used, it means that etiology is unknown. In this condition, idiopathic vasomotor rhinitis, it is an inflammatory nose condition with unknown etiology. And what happens that the normal defense mechanism is exaggerated due to some environmental triggers, such as change in temperature, humidity, exposure to irritants, cigarette smoking, or strong odors, chemicals, all these are involved in such conditions. Symptoms are again nasal blockage, anterior nasal discharge, posterior nasal discharge, sneezing. Seasonal variations and ocular symptoms are almost always missing because these are not associated with the seasonal changes. These are just affected with either with the environmental or some other environmental conditions. If you do a skin prick test, which we use for the allergic condition, that will usually come negative because it is non-allergic. Then for the treatment, first of all, the mainstay of the treatment is to avoidance of the obvious targeting triggers, factors which are causing these disease or these conditions. For that is important. Then the occupational environmental rhinitis, that is airborne agents. You all know that allergic or non-allergic hyperresponsiveness, those working in the factories or exposure to environmental pollutants or such chemicals like glue, salt, solvents, etc. Wood workers that exposed to the wood dust or grain. These all are irritants, and the patient get having rhinitis, and such rhinitis is called as occupational or environmental rhinitis. History is usually important and give a proper clue to you, because the causative, the etiology or the cause is lying in the history related to his or her environmental, occupational exposure. So again, the nasal symptoms of blockage, water discharge, or something like this. Clinical findings usually are non-specific because it differentiates from and vary from patient to patient. And assessment of nasal patency, again, you have to examine. Sometimes you can get two pathologies in the same patient. Environmental factors and occupational factors are there for the as a causative agent of rhinitis, but you can see some other conditions, some other disease in the patient which may contribute. So for the treatment, you have to ask the patient or direct the patient to avoid such exposure irritants, either by changing the job, which is sometimes very difficult to do, improve ventilation and the use of mask, which nowadays all the people are using. Topical corticosteroids, this have a role. This again have a role in environmental rhinitis also. Hormonal conditions, physical and pathological endocrine condition, these symptoms are worst. This, what happens, it usually in the female it occurs, and atrophic conditions occurs. Atrophic rhinitis, hormonal rhinitis, in which it is associated, related to these hormonal imbalance. It occurs usually in the puberty, pregnancy, menopause, and the patient is experience a blockage or watery discharge or sometime epistaxis. As I have written that the symptoms are worse during the last trimester, especially in the pregnancy, and relating to the blood estrogen level, and it resolves the delivery. Mucosal atrophy can be seen after menopause, and some other condition like hypothyroidism, acromegaly. In all these conditions, the treatment is local, that is saline Dutches. But if it is ineffective, then the topical nasal corticosteroids and pseudoephedrine is given to the patient to treat. Drug-induced rhinitis, aspirin and non-steroidal anti-inflammatory drugs are on the top. Aspirin tolerance typical, it increases the nasal congestion. But some cardiovascular preparations are also studied for such condition that can cause rhinitis. And that is a drug-induced rhinitis. And if you change the, if it is confirmed that yes, this drug is, the patient is getting the symptoms due to this drug, so treating it with some other drug alternative or stopping that drug, that can be effective. Some topical ophthalmic beta blockers or clonazepam or oral contraceptives are also studied in such condition that can induce the rhinitis. Yes, one condition, that is rhinitis medicamentosa. This is the very important in a sense that we can come across, and we can see that the self-medication of the people from medicine store, they take a nasal decongestant spray for nasal obstruction without knowing what is the underlying cause. So prolonged use of such topical decongestant, nasal spray, nasal preparations, they are they can cause rhinitis. And what happens? The patient in such condition, the patient initially he or she get very much relief from such preparations, but later on a rebound congestion occurs. Patient take this nasal preparation, and after a few hours, again he or she need that preparation to for the patency of the nose, nasal cavity for the nose, that they can be get relief or be easy. But there is a more blockage or congestion if these nasal preparations are not used continuously. So ultimately, a mucosal atrophy develops due to repeated, due to prolonged use of these conditions. So only these preparations are recommended for 7 to 10 days in specific conditions. Sometimes we do nasal surgery when we advise a nasal decongestant for 5 or 7 days, or on the temporary basis, but not a prolonged use. Prolonged use is lethal in this condition. Food-induced rhinitis. There may be some food that curdlants or preservatives that can cause rhinitis, or alcoholic beverages, vasodilatation associated with the nasal blockage. Atrophic rhinitis. This is a very important condition, disease which we sometimes come across, and the patient is very difficult sometimes to be treated. The primary one is their primary, secondary. The primary is due to infectious bacterial infections, Klebsiella, and also related to environmental factors and general health, depending upon the general health and environmental factors. In such conditions, what happens is the progressive atrophy of the mucosa and the loss of turbinate bone, choana, and resulting in capacious space full of foul smelling. What happened that the mucosa of the nasal mucosa is destroyed. It is almost destroyed. And the mucosa nasal cavity is widened or spacious with no mucosal proper lining, functioning mucosa. There is no functioning mucosa. So there is a foul smelling, crusting, and bleeding is very common. Epistaxis is very common in such conditions. This is the primary condition that is due to infection. In secondary atrophic rhinitis, it is not due to infection usually, but it is either due to excessive surgery, multiple nasal surgeries, mucosal lining of nasal mucosa is traumatized or it is destroyed, or due to some accident, trauma, like this. And one condition is the radiotherapy, in which if there is some paranasal sinus tumor or head and neck tumor for which the radiotherapy is given, and these radiations can destroy the mucosal lining. And other are chronic glomerulomatous conditions, variant granulomas, or these can also come. Symptoms are foul smelling and copious crusts, and it usually bleeds if it is touched or the crusting is removed for clearance of the nose. And it can extend to the nasopharynx. And if the patient usually is having a blockage or choking sensation in the throat. There are nasal blockage due to drying effect is. Local treatment is again with the saline or clindamycin. Lubrication is important with 25% glucose or glycerin drops on regular decrusting of the saliva. Thanks. Okay. Have a look and listen to the topic very carefully. And I will give some assignments later on. And again, the assignment should be sent on regular basis whenever I give you within a specified time on the email address you all know, not on a WhatsApp. And on the basis of those assignments which I receive in a proper time, not beyond the specified time, in a proper time when I get your email assignment by my email, I will mark it, and your marking will add to your internal assessment. And on the assignment from the students which I get, those students will be marked as present. So present means that they will have marks in the internal assessment. I have told you before that this time with the fourth year, we have marked their class attendance and the test which we have given to them. And on that basis, we have marked their internal assessment. And the most of the students get very much benefit from that. And some students which were taking it as a gupshup, so they were affected very worstly. So be careful. Thanks.